Now, buried in your comment, and I was listening, was this whole thing of, well, they're going to get admitted. Who's going to get admitted? Who gets into the hospital with this problem?
Well, several studies recently did very nice surveys among emergency department doctors and asked the physician, for the patient that you admitted, what was the reason for admission and what were the secondary reasons? And what they found was that in about 80% of the cases, the most common by far reason to admit someone is the need for IV antibiotics. And in about 40% of the admissions, the need for IV antibiotic was the only reason to admit someone. So they needed to get something that's only given. The perception is that it's only given in the hospital, and therefore you need to admit them. In fact, many of those patients had no comorbidities, and those who had comorbidities, most of them did not have any exacerbation of their comorbidities, and there was no concern that their infection is out of control, and just for monitoring, they need to be admitted.
So this was simply pragmatic, which is IV antibiotics are what you need. You can't get that in XYZ, home, office, whatever. Welcome to the inn. Is that it? Is that a fair reason to admit somebody?
I don't think so, because I think if you also look, many times these are limited comorbidity patients. They're not that sick in terms of you know, what we would associate a lot of times with being sick. So, you know, as he mentioned, IV antibiotics are pretty much the main reason why these patients are being admitted.
But you said it to yourself. These are not sick folks for the most part.
Absolutely.
They just need a therapy which mechanically is tricky in some settings to give outside the hospital.
Logistics are the issue.
But let's pull this back to money. Not sick. Just need an IV, just need some antibiotics. Yeah. That should be cheap, but now you're occupying some very expensive real estate.
So I think that you touch really the heart of the point. So we talk about the incidence, we talk about the increase in skin infections, and it causes a major issue. First of all, for patients, you know, infections that could be treated at home, now they need to be admitted to the hospital. Most people don't like that. It's an issue for hospitals, interestingly, because patients with skin infections tend to stay in the hospital longer than what the hospital is going to get reimbursed for. So skin infections are not the best way to fill your beds if you can do it otherwise. And of course, it's a major issue for the community because we end up paying for that. So we now are in a kind of crisis situation, and the biggest question is how do we do it better? But to be fair, until recently, we didn't really have any options. You know, someone came to the emergency department and said, I took this, I took that, I took Bactrim, I took Caflex, it didn't work, now it's 2 or 3 days, I have a fever, and the ED doctor is looking at the cellulitis, and the next step is IV vancomycin, and the only way to give vancomycin is to admit the patient. So there were no other treatment options.
Well, let's explore some of these issues that you brought up, because a lot of them are whenever you discuss money, it's bureaucratic to some degree, because there's somebody out there evaluating your treatment plan, your program, and your reimbursement. So the first thing is they're going to be, you said, in the hospital longer than what the reimbursement folks are going to pay for. Yet there are protocols for IV antibiotic therapy. How come the reimbursement protocols aren't in sync?
You know, I think, you know, patients when they come in, they follow, you know, kind of to your original point was length of stay. You know, they're staying for at least 5 days. Many times we've looked at our numbers go even 6, 7, 8 days. And it's just being able, case management, being able to get these patients out. You know, many times you can't, it's the DRG that loses money. So these patients, on average, every patient that we admit, you lose money. And I think a lot of times it's case management being able to set these patients up.
So here's a DRG, right? The DRG says, I'm going to make up a number, here's 20 cents, go treat this patient. You know you can't do it for 20 cents. If you're going to follow all the protocols in the infectious disease literature, it's going to cost you $20. Where's the disconnect here? Is it just some bureaucrat who says, no, I'm not going to pay you for it? Or does it make good sense to find something that you can use that will get them out of the hospital more quickly?
I think it is. I think it's both sides. I think it's finding a way to either not admit those patients or targeting them and getting them out for an earlier discharge.
So if somebody has to stay for medical reasons and the hospital keeps them, and if there's a DRG, they're going to lose money. If there's no DRG, there's still a penalty. What kind of penalty does the hospital look at?
Well, you know, again, I'm not a reimbursement specialist, I should say that. So, but I think that when you look at the DRG, there are some patients who stay for a short period of time. There are some patients who stay for a longer period of time. Just that with skin infections, they tend to stay longer than the DRG would. I mean, and you understand that. I mean, there's no there's really no reason from payers to incentivize hospitals to keep patients longer. But we are in a DRG era, and people are that's how we get paid. And so I think that at the end of the day, we're stuck with that.
Yeah, and I think a big concern for us is readmission. You worry about these patients.
Yeah, I was going to get to that. Sure.
Yeah, if they're coming back within 30 days, your hospital's going to eat that cost. So that's where I think a lot of the concern comes in.
So let me see. If I'm going to put on my cost accountant hat for a minute, okay, I'm going to lose money if I keep them longer than what the DRG will pay for, or what the length of stay protocol is from this insurer. But if I send them home too early, they're going to bounce back, and I'm going to eat that money.
Absolutely.
So maybe it's cheaper to keep them, eat a small amount, than bring them back and eat a big chunk.
Absolutely. In this day and age, compliance, adherence, such big issues, I think sometimes being able to see them in the hospital every day, know they're getting their IV antibiotic, it's easier to think maybe I can prevent that 30-day readmission.
Right.
Yeah, I agree with that. And first of all, as a clinician, I think that the cost comes second to patient's benefit. And I think that, in fact, in this case,
You, sir, are a dying breed.
Yeah, well, I think that if you do it right for the patients, the cost will follow as well.
Okay.
But I think that, first of all, you have to do what's right for the patient. And in this case, I think it's aligned with also reducing your cost. This is a great opportunity with those two things. And then when you talk about cost, I just want to mention one thing. Cost for one person is different than cost to the other person. So you can talk about length of stay, but then the pharmacy director sees the cost of the antibiotics, someone else sees the length of stay, someone else who's the payer is looking at the overall cost of the admission, and we, as the society, pay for our premiums, and so everyone's cost is different, and I think that as we discuss cost, and I have this suspicion that we're going to discuss it further later, I think we have to take it out of this silo mentality and actually look at what's worth investing in and what's not. I know you're an ICU doctor, and when you see a patient who's a little diaphoretic and maybe unstable, or maybe you are in the ICU, but an internist, when he sees a patient and says, I'm really concerned about this patient, not sure what's going on, maybe he's bleeding, God knows, we'll send him to the ICU. Every day in the ICU is $2,000, $3,000. Why would he do that? It's so expensive to send. Why do we have ICUs? And so I think that the question is not what's the cost, but the question is what do we get for the cost, and how do we come with rationale? So just as a segue.
But you mentioned again, there's lots of stuff buried in the stuff you say that's fascinating, which is it's time to get rid of silos, right? I've always made this argument, and I've always gotten strange answers. If I'm going to save money at the pharmacy level, maybe cost a little more on the bed occupancy level, but at the end of the day, the net is a savings to the institution. But that's not my money. Right. My money's in the drugs, and I'm losing money here. How do you get people to talk to one another?
That's actually a fight I deal with every day because I have a manager, depending on what antibiotic we use, you get into the more expensive ones, they may treat the patient better, they may get them out faster, but trying to make administrators understand that that was the best antibiotic in that case to use is always hard.
I think they understand it, but there's something about budgets. Mm-hmm. My budget is not your budget.
Absolutely.
And the whole hospital budget doesn't really impinge my decision to kick you out because I'm going to lose money on your next dose of vancomycin.
Absolutely. There's an inpatient budget for drugs, and antibiotics get lumped into it. And when they see it tick higher, that's what they see. It's not the outcome side of it. It's not the right therapy sometimes. I think it's that magical big number. Do
you have any insight into how this evolved? Because it doesn't make clinical sense, right? If I can get somebody with a moderate stay with a cheaper antibiotic, or even outpatient with a more expensive antibiotic but never comes in, isn't that better?
Well, I think that when you start to fragment your institution and look at different parts as cost centers, and all of a sudden they have to justify their existence, and as you know, in some parts of the country, people are recruited to the job in order to contain cost. And so I think that when you do that, you really narrow the perspective, and you need to have a broader perspective. I again think that if you do what you need to do to benefit patients, this will follow with shorter length of stay, will follow with prevention of unnecessary admissions, and at the end of the day, it will also follow with the pharmacy budget. But you have to take the approach in which you're looking at that in a systematic way, you monitor that, you document that, and you actually can show that, and then the system, I think, will accept that.
And I think with antimicrobial stewardship, what we always like to associate that with is cost savings. It's always the term that's tied with it. And, especially early, you usually see a return on that, and it tends to plateau. And they start coming to you, and, why aren't you saving us more money? Why? And so I think sometimes it's just tying those two words together.
But again, I think that you don't start with the cost. Again, I'm sure I think you really start with putting together a system in which people buy in, people understand it, and you ask, how do I benefit my patients in a way that's cost responsible, that I can justify the cost. And I think that it starts with putting together a team that really cares about patient and patient care. And I think that it is important. That's why I brought the example of the ICU, because no one doubts that if someone needs ICU care, they should be in the ICU. That's why we have ICUs. And in a way, if you think about the more costly antibiotic that can save a life, it's just the same, principle-wise, it's just the same as an ICU bed, only that it's much cheaper, even if it's the most expensive antibiotic.
And I think you've got to collect numbers. You know, people in the C-suite, that's what they're used to. They're used to being given numbers. And I think if you can show them that what you're doing is benefiting patients, maybe it's saving money, but more than anything, you've got to be able to show them more. And usually they're kind of interested and excited, and they just didn't know what all was going on.